We helped bring the first malaria vaccine to market. And really my job is, okay, if we can do that for something as critical as a malaria vaccine, how do we think about that for AI?
A lot of differences between the promised impact of AI and the actual impact of AI on the ground.
The trove of money that exists is being spread out across so many things, many of which don't work. What healthcare service providers are trying to do is, how do we make sure that they are able to provide safe, effective, locally relevant advice to people who are in need of healthcare but can't access a physician?
What do you think would create the most impact in 5 years when it comes to AI and health?
If I was to be selfish and do the thing that I've always wanted to do, I would do the diagnostic thing, Ben. But if you're looking for the greatest impact, is the really boring building better health data infrastructure.
Hey everyone, and thanks for tuning into another episode of the Chief AI Officer Show. Today, I'm excited to bring you Bilal Mateen, who is Chief AI Officer at Path. Bilal, thanks so much for coming on the show.
Thank you for having me, Ben. It's a pleasure to be here.
Yeah, before we get into it, can you give a brief introduction into your background and the work that Path is currently doing?
Absolutely. So I grew up around the world, born in Pakistan, but did my medical training in the UK, trained as a physician, and then very quickly realized that I probably wasn't going to be a doctor for life. So spent a little bit of time in academia. I'm currently an honorary professor of machine learning for health at the University of Birmingham in the UK. And then I serve as the Chief AI Officer at Path, which is this international NGO. We're about to celebrate our 50th anniversary, and really throughout its history, it's been focused on health innovation and product development. So historically, we've done a lot in vaccines, diagnostics, medical devices, and health technologies, and really service delivery in what we would consider the emerging economies, low and middle income countries, really where the need is greatest, we'd argue, all with the purpose of trying to close the global health inequity gap, or the equity gap that exists. And to give you an example of really how instrumental Path has been prior to my arrival, I can't really claim credit for it, but we helped bring the first malaria vaccine to market. So the original wet lab work was done at the Walter Reed Medical Center, and then Path came in to support GSK, who was the big pharma product development partner, go through the phase 3 trial that happened in Sub-Saharan Africa, proved out the efficacy. We then took it through the WHO pre-qualification process. We're now working with Gavi to support the rollout across all of the malaria endemic regions that exist in the world. So we were pretty instrumental in filling several gaps to help the product get to market. And really my job is, okay, if we can do that for something as critical as a malaria vaccine, how do we think about that for AI? Right? Not just how do we use AI to make our vaccine development work quicker, more efficient, more effective, but also how do we think about AI-based medical devices? So a computer vision-based diagnostic solution for skin lesions, or identifying parasites on a microscopy slide because you don't have expert microbiologists everywhere that you need them. That's really what me and the team focus on. The initiative has been around for the last 12 to 18 months. It really kicked off with my appointment. And we're trying to figure out how can we help the buyers that exist in these markets understand what's useful, what works in their context, and really what they should put the limited dimes and dollars that exist behind.
Yeah, I'm excited to go into some of the specifics around that. I mean, it's an exciting mandate and very interesting and fulfilling work, I would imagine. It's not every day that I speak to someone that is developing malaria vaccines and bringing them to market, or any of these other diagnostic tools that ultimately save lives. So I'm really excited to get into some of that. Backing up a bit, personally, you were practicing physician, you studied in medicine. Why did you leave a clinical medicine career to bet your career on AI? And particularly, the link to global health, I guess, is obvious, but yeah, why AI?
So I actually had a detour in my career. I left medicine to go work for one of the largest philanthropies in the world, the Wellcome Trust. And at the time, it was the second. I think, given the advent of weight loss medication, it's now the third, because the Novo Nordisk Foundation has pipped us out. But Wellcome still allocates something like £1.6 billion a year, about $2 billion a year, to science and health research. So I spent just short of 4 years there, helping build out the digital technology funding portfolio. So really thinking about how does digital technology, again, accelerate science and health across lots of global health challenges, but really also discovery science, right? Just doing science for the sake of science in the hope that in 10, 20, 30 years, the discovery, which may not look immediately relevant, suddenly becomes hugely relevant, right? I think the example that everyone loves is mRNA vaccines, right? The original DARPA investment, I don't think anyone fully understood the value of. And then along comes the COVID-19 pandemic, and suddenly it's a super effective solution that we're able to roll out globally and have a kind of non-trivial impact with. So my journey was, I loved medicine. I was talking to a friend recently, talking about how there are days I sometimes think I might go back. Fortunately for my potential patients, I didn't give up my license. So I won't be going back anytime soon, but it was a desire for scale, right? As a clinician, as a physician, you can treat one patient at a time in a given day. Maybe you'll see 6, 12, 18, 20, 30 patients if you're managing them on a ward round, but there is a number, right, which physically you as an individual, you and your team can help. Even if you go into a management post, you're a step further away, but there's a number of people you can directly help. And my reflection constantly was, okay, I want scale, right? How do I do more? Even if I'm not as proximal to the work, how can I use what levers exist and are available to me to have the greatest impact possible? And so it felt like a natural transition to go from actually doing the service delivery to funding the science that I thought would be the basis of the next great health intervention that could save millions, if not hundreds of millions of people. And having spent 4 years doing that, while it was incredibly rewarding and we funded some pretty extraordinary work, that my reflection at that point was, I'm too distant from it, right? These are someone else's great ideas. I'm helping make sure that the philanthropic funds that I get to help steward end up going after the investments that we think might have the greatest impact, which is a phenomenal privilege. But you begin to go, oh, I have great ideas too, right? Like I want to get my hands dirty. I want to build something. And so the next step was, okay, how do I move to an organization that brings me slightly more proximal to the doing? Maybe not in the same way that a clinician does, but also has the opportunity for scale. Path works across almost 80 countries globally, right? Several thousand staff members. At our peak during COVID, we were helping manage investments that were almost $500 million in total, right? Enormous amounts of the confidence of philanthropists and donors of both the bilateral and multilateral ilk, trusting us to do interesting product development. And so I have ended up in this space where I've gone, okay, I think I've got scale, I think I've got proximity, but the more times I go through a project, maybe not today, maybe not tomorrow, but I'm starting to think about, okay, what do I want to do next? And the itch that I don't think I've fully scratched is getting to build something, right? There are certain ideas that I'm certain could have an impact that when you're, I don't want to say figurehead, I don't think I'm that important. When you're a member of the senior management of an organization as large as PATH, right? I spend a lot of my day trying to pitch good ideas, but then platform other people and build a team that allows us as an organization to respond to it. I don't think I've fully gotten my hands dirty again. So maybe in the next couple of years, I build something myself. Yes.
It's, an exciting challenge to take on. It's not uncommon, particularly the people I interview on this show, as you get more senior, particularly in organizations, to your point, right? You get further and further away from the actual work. And it is frustrating, right? If you're someone who loves your craft, loves to build, there are, as you said, like scale has its own rewards to some extent in terms of what you see happening and what you can influence, but it doesn't quite whet the appetite of building in the same way. But you have seen a lot of major tech investments. You've overseen them both in your time at the Wellcome Trust and at PATH. I'm sure you've seen a lot of differences between the promised impact of AI and the actual impact of AI on the ground. Yeah, what are your views on that? Do you have any examples of where it met the mark, where it disappointed? Are there any themes there?
I think the single greatest theme that I walk away with is we allowed ourselves to be sold a lie right? The more and more you look at AI in health, the more you realize that we are holding it to a different standard than we have all of the other interesting stuff that we've done in health innovation and product development. For some reason, where it concerns digital technologies, AI-based medical devices, we seem okay letting them get away with just telling us how accurate it is. It kind of is tied to this idea that you see a lot in American regulatory processes called substantial equivalence. You will see the headline of a paper saying this diagnostic radiology tool is better than a radiologist, right? It's 20% more accurate. It's got superhuman capabilities. And you go, if only medicine were that simple, right? If it was as simple as me looking at the chest x-ray and going, that person's got a pneumonia, and suddenly the person felt better, right? They were healthy, they went off and lived their life, the world would be a very different place. But fundamentally, health systems, health service provision is really complicated, right? And just getting that diagnosis right is one cog in an incredibly complicated machine. And what we don't do enough is test whether making that one cog more efficient actually produces a machine level benefit, right? Does improving the quality of this diagnostic test lead to a benefit for a human being? There's loads of research that predates the AI era, back from the early 2000s, which shows that when you compare diagnostic tests head to head, right, like simple biochemical tests head to head, having a better test guarantees you no benefit to a patient downstream. Okay, about 1 in 20 tests will actually benefit a human. That's not to say there isn't other value, right? You could save money, you could make the system more efficient. There are lots of ways to measure value, but I don't think that we've held a lot of the AI-based innovation to the right standard for the last 10, 20 years. And you can see it in the history of what's happened with breast cancer. So breast cancer computer-aided diagnostics for screening was actually the first product approved by the FDA in the mid-1990s. The first randomized controlled trial that showed us that it benefits a woman was published 6 months ago.
Wow.
Right? 30 years on. That's how long it's taken us. And we've gone through lots of cycles where lots of people have published great research that shows it doesn't work. Others have suggested it might work. And you're like, okay, but we had a method, right? We have something that works. Why didn't we do this before? And I think it's been one of the big gaps. How do we convince people to invest in the really complicated, hard evidence generation process to prove that this works? Because no one has asked for it, or not enough people have asked for it.
I love that insight because it speaks to, right, the thing that many people get into medicine in the first place, right? Like producing patient outcomes actually benefiting the humans at the end of this chain. And how it's so easy to lose sight of that when you focus on the technical aspects. And like, yes, of course, it's going to be immensely difficult to measure the full impact of something and in its full implementation, like when you're just looking at one step in it. But ultimately, that is the goal. So that should always be what we hold it against as far as a benchmark. And hearing you talk through it, it's funny because although the stakes are different when it's not health related, it's not uncommon in enterprise AI and just AI generally that startups or the solution providers over focus on some minute technical aspect and like the difference in accuracy, when ultimately the stakeholders don't really care about that. What they care about is like the job that they're trying to achieve and like, does it actually enable me to achieve that outcome? And in this case of patient outcomes, it seems like maybe that is a big disconnect. So I love that specific insight in terms of health, but also what it tells us about the broader market. And, you know, why do you think that disconnect happens? And also, are there other disconnects in relation to just how we adopt AI that you think are causing a lot of issues in this industry?
So to answer the first question of why do I think it happens, it's related to the second one, right? We're not rational buyers right now. There is so much money in the system, believe it or not, right now for AI-based procurement, where I think people are just making dumb decisions. And the moment you realize that they're not malicious, they're not proceeding with ill intent. There is this fever pitch need to be able to demonstrate to your leadership that you've done something in AI to the point where you almost lose all nuance, right? It stops being about how have I generated value for the business. As soon as you've said, oh, we bought this new Copilot, right, that helps our staff write code 1,000 times quicker, right? That headline statement suddenly means people have stopped caring. You've won, game over. No need to do any follow-up. No need to do any monitoring or evaluation work. No need to actually continue to monitor this investment to determine whether it continues to provide value. We've succeeded because ultimately the task was just get something AI in the door to make us look modern. And it's really unfortunate because what it means is the trove of money that exists is being spread out across so many things, many of which don't work. Whereas if we built in the incentives to figure out what did, I fully suspect we'd go further and faster because we'd be actually throwing money on the fires that deserve it. So yeah, and I don't think this is just true of low and middle income country markets. It's kind of everywhere. I see it with a lot of corporate partners we interact with. There is just a need to be seen to do something. It's, what's our AI strategy? What are we buying? I was like, don't worry about what you're buying. First, figure out what the problem is you have, right? And figure out what you can do to meaningfully shift the needle on that problem, right? Some problems will be amenable to an AI-based solution. Some of them will be amenable to a Gen AI-based solution and you'll get to make your board really happy. But not everything needs it. And I really wish that we could kind of revert to being adults and go, no, it's okay. It's okay to not do the AI thing this once. And like, if I could do anything, Ben, here, I want to give everyone permission to go back and say there was this chief AI officer one time who said it's okay not to do the AI thing. He's happy to retire.
Yeah, don't chase the shiny object and have a real think about what you're trying to achieve and what's the best path to get there. And it might not be AI. I see that over and over again. Also, like a lack of real awareness of what is your strategy and how to achieve it among companies that causes that shiny object syndrome and like so much money wasted, so much time wasted. And I think, it's also why you're seeing things like that recent, I think it was MIT study on, the lack, how many enterprise pilots fail, like it's around 95% and things like that. Like because of this, right? Like the root causes of that lay in what you're talking about. In that process, right, you mentioned the health ministries in low and middle income countries that you work with, like how they're evaluating, maybe they're chasing shiny object syndrome. What do you think, what are their actual concerns? And are vendors misreading what those concerns are? And that's why the problem that you just mentioned is happening?
I absolutely think we're misreading the market because fundamentally the concern is a burned out workforce that was insufficient to start with, right? So for those that are unfamiliar, if you think about Sub-Saharan Africa, the number of physicians that you have per 100,000 people in the population falls well below the World Health Organization's suggested minimum, right? At the point where you don't have enough physicians, you begin to get creative. And the creative solution that's been engineered over the last 10, 15, 20 years is how can we push more responsibility to less well-trained cadres of health worker to try and offload what needs to happen in a facility by a specialist, right, in an attempt to achieve kind of universal health coverage through a comprehensive primary healthcare system. Like, ingenious, smart. Like, I think it's a great idea, assuming you get it right, right? And what we've done is we've given responsibilities around, let's say, supported malaria screening and provision of anti-malarials, or supporting antenatal care follow-up and visits to community health workers who at the best of time maybe have had a couple months of training, probably less if we're being honest. And when you think about kind of the breadth of responsibility they're being given, I think most people would be shocked to figure out how much time they're spending being taught about how to manage a mental health crisis. So what ministries of health, what healthcare service providers are trying to do is figure out how do I support these individuals, many of whom are volunteers and sometimes are being incentivized for doing certain things. How do we make sure that they are able to provide safe, effective, locally relevant advice to people who are in need of healthcare but can't access a physician, right? Often at the last mile, where access to certain medicines, to certain specialist instruments is very, very limited, if at all achievable. You're trying to figure out how to support that person who's already overburdened, and you're trying to figure out how to support every other level of health worker in that system who, again, doesn't have everything they need and is being asked to do way too much. And the solution we've all defaulted to is, the standard of care is, of course, variable as a consequence of this infrastructure we've built. So let's just give these people more and more complicated clinical decision support systems, right? How can we get them to extract information in a structured way, walk them through some sort of flow chart, or capture the conversation and tell them what the diagnosis is? And you're like, okay, that's useful. But what would be a lot more useful is if I understood anything about this individual, right? I have no health record about them because every time a document is produced, it's a piece of paper and that piece of paper goes somewhere. So when I end up having to send this person from the community into a facility to see a doctor, I'm lucky if they're carrying a tiny postcard's worth of information with them, right? More often than not, they take the information that they should go to a facility, they rock up, and someone has to redo the entire process. And one of the most, I think, best investments, maybe not best, it was pretty damn good. One of the brilliant investments we made when I was at Wellcome is we gave a grant to this group called DataKind, who you might know. They're a data science charity. They worked with this group called Riders for Health in, I believe, Kenya. And what they did was they created this really low weight computer vision based tool where they were trying to digitize the document that went along with the sample that needed to be processed by lab. So what would have happened normally is someone on a motorcycle goes out to the community, collects a sample, has a piece of paper, goes back, hands it in. And that piece of paper, from when it was collected to when it eventually got digitized, would take 90 days. The computer vision solution reduces that to 1 day, right? It comes back, someone takes a picture of it, immediately digitized. And you go from a world in which there was no world that information was relevant 90 days later to doing real-time policy and planning about where there's an outbreak, to suddenly, I can do something meaningful as the person in a ministry in charge of figuring out where I deploy vaccines or where I might need surge staff. The simple operational solutions, I'm convinced they're going to have the greatest impact. And yet, I'm willing to bet in the next week someone else is going to pitch me a clinical decision support system. And no one will pitch me an operational solution. No one wants to do the unsexy thing.
Yeah, it's funny. Over time, through so many conversations, I have learned that the boring, unsexy things are usually the things that are driving by far the most impact. And it doesn't matter what industry you're in at all. And it's funny that almost essentially what you were to suggest is like a lack of CRM, like the most basic information about each patient, and a solution designed to support that is something that has massive impact, but everyone leans into like the sexy diagnostic tool. And it's funny because I think that's happening everywhere with AI to some extent, where I feel like the investments that are being made in using AI to structure, clean, enrich data, whether that's through computer vision or just through like language model processing over files, all of that stuff, that is driving immense value. And almost nobody talks about it because like document processing is not an exciting thing to talk about, but it's one of the like biggest unlocks for, this current wave. And yet, like you said, we always have the conversations around the diagnostic tools, the like exciting new, whatever, the robotics, whatever it might be, like that's always where the conversation goes.
Whereas predictive failure analytics for medical devices that would tell me when I need to do preemptive maintenance of a device so that it doesn't break, right? Which has an outsized cost versus just doing some routine maintenance. Find me a donor that's willing to pay for it.
Yeah. And so that's interesting. Is the problem do you think, are there a lack of solutions in the marketplace for that sort of thing? Or is there a lack of appetite on the side of the donors to invest in that? And I'm assuming to some extent they're reinforcing each other, but like where's the bigger gap, do you think?
I think we have an ineffective market, and you've begun to point out why it's ineffective, right?
Right.
So part of it is philanthropy and donors are well-meaning, but are not the solution to the problem we have today. And those that understand or could be helped to better articulate their problems aren't actually the payer in these ecosystems, right? they're using philanthropy and donor dollars often to underwrite the work, at which point you have someone else saying, oh, I think this is the interesting thing that should be done, or I want to be able to go back to my boss and show them the interesting, creative, innovative thing we build, not the unsexy computer vision document digitization solution, right? So you've got this mismatch between who the buyer is and who is, let's be honest, setting the agenda. And to your point around, is there a lack of solutions? I don't know if it's a true lack of solutions, or rather just a response to the market. It's not impossible to build these solutions very quickly. There are people that are more than capable. They're just distracted by the fact that when I show up with my millions from insert donor name here saying, let's create a clinical co-pilot and deploy it using OpenAI's GPT-4o, they go, great, cool, thanks for the money, Bilal. We're definitely going to do what you're incentivizing us to do. So I think if you sat down and broke it out, you could summarize it as we have a really efficient marketplace for these products, and there's probably 4 or 5 interventions that would need to get it right. But it's not as simple as kind of one broken thing that we can do something about tomorrow.
Yeah, complex problems usually have complex solutions. So in that world, right, when you're thinking about the measurements, you hinted at it in kind of your first response at the start of this conversation in terms of that mismatch between the overfocus on diagnostic tools, because it's very easy to measure accuracy versus measurement of like the patient outcome. How do you think about measuring ROI or impact of AI in health when the beneficiaries are these communities? It might be patient outcomes, like you're not seeing a return in terms of income. So yeah, what does that calculation look like? How do you justify your investments?
So I think sometimes you can see a return. Interestingly, what we've begun to talk about internally is cash releasing efficiency gains, and not cash releasing efficiency gains. And most solutions fall into the latter category because the efficiency gets cannibalized by the unmet need in the ecosystem. So if a clinician is able to see 2 more patients, right, you don't send them home X number of hours earlier because they've seen all the patients in the clinic. Believe it or not, a whole bunch of people that don't get seen every day. So you realize the benefit through some, I don't want to say abstract, but several degrees removed benefit in terms of health outcome, right? So you need to take a step back and you need to go, okay, because I'm seeing those extra patients every day, X number of people aren't showing up to the hospital with necrotic gangrene, if this is a diabetic clinic, right? Or something else where the issue that they had has gotten so much worse, where there is now a much outsized cost where you could have done preventative care for a lot cheaper. So those are the non-cash releasing efficiency gains. But every so often you come across a unicorn, and I'll talk about some work that we're doing in Kenya with a brilliant partner called Penda Health. So the chief medical officer is a guy called Rob Coram. The product was really Rob's idea several years ago, funded by the Gates Foundation. And almost a year ago, right? Time has flown. It's not several years, it's several months. It's felt like years. What Rob did was into the electronic healthcare record system that Penda runs. They run clinics, primary healthcare clinics across Nairobi County. They built this co-pilot into the electronic healthcare record system where if a clinician wanted support, it could click a button and the LLM would read the documentation and come back with hey, based on what you said, I think it's this. I don't think you should prescribe this. We made some changes to the version we've taken into the randomized controlled trial, which does try and measure where is the patient level benefit. So in about a month when it comes out, we'll be able to tell you that. But the cool thing that's happened is that the LLM has been coming back and suggesting that certain drugs not get prescribed. Right? Understandably, lots of people get prescribed an antibiotic when they have clearly a viral disease. They shouldn't be given the antibiotic. And Rob, a few months ago, sent us his leadership team's readout, and they had been looking, they're a social impact for profit. They're a private enterprise. He sent us their readout from their pharmacy sales in like this little table. And he was like, Bilal, over the last quarter, while the trial was running and this tool was active, we've made 50,000 less. $50,000 fewer dollars. Now, you can imagine from Rob's perspective, he's thinking, I've lost $50,000. But when you think about it from the health system perspective, if we were to scale this technology across the health system, right, what's actually happened is the LLM has suggested that inappropriate antibiotics or inappropriate steroid prescriptions, which is another example, have been averted. And that means that both the individual that would have paid for those drugs has saved money, and or the national insurance scheme that would have underwritten the cost of those drugs has saved money. So whilst Rob, bless him, he doesn't talk about it this way because he does actually believe the social impact mission. I should say that. Think of it as 50,000 lost. But from your and my perspective, we can see that as 50,000 gained, right? Like that's
Right.
true cash release from a system. So that's how I think about ROI, right? I would love to anchor everything in some patient level benefit. I'm a rational human being, right? Not everything is going to be measurable in its impact on an individual life. There are lots of other ways that we are changing the system. For example, through reduced costs, through increased efficiency. The challenge that I think we all encounter is how do you measure those effectively? And how do you demonstrate that that isn't just by chance, that if you do use formal research methods showing that with a control arm, it wouldn't have happened without the tool that you were introducing.
Yeah, that's such an interesting one. At kind of a higher level, I almost feel like it's this thing as well of the short-term focus, or like the tunnel vision focus on a particular metric obscures like the wider picture of what's happening. And I think we see that across a lot of organizations with AI, where like had you taken the short-term immediate ROI focus, you might have killed that, but you take one step further and think about like the broader system and what you're actually trying to achieve. And it's a no-brainer in terms of the adoption. Maybe not for Rob and his business, but yeah, it's a very interesting example.
That and the flip side of if you over-index on the short-term benefit, if you can see it without recognizing the total cost of ownership.
Yeah.
Right. Sometimes you make a bad decision because you didn't realize that actually this requires profound reform of how you deliver care, and the fact that you were able to make it work in this one really isolated pilot doesn't actually speak to what are the total costs for you to implement it across your entire organization or across an entire health system.
Yeah. I mean, I think that holistic view is often hard to get or hard to champion and when an organization has misaligned incentives, but it's always the right course of action, I think, in the long term. Looking forward a little bit, if you had to bet past entire AI budget, right? Solve one global health challenge. Maybe it's this document processing, like the simple fix, right? But like, what do you think would create the most impact in 5 years when it comes to AI and health and on the things that you work on?
Again, the unsexy answer is, we should just invest in the underpinning digital infrastructure, the data systems, the health information systems, making those robust, making sure we have effective routine data capture, making sure there are systems onto which these AI systems can piggyback, right? Mm-hmm. So that solution that we talked about, which Rob implemented, only works if you have a comprehensive electronic healthcare record system, right?
Right.
In most low and middle income countries, you can't assume that, or you shouldn't assume that you have that kind of infrastructure to piggyback on. So I think if I was to bet the whole budget, it probably wouldn't be enough by several orders of magnitude, but that's the smart bet. If I was to be selfish and do the thing that I've always wanted to do, I would do the diagnostic thing, Ben, because the reason I got into the AI game was I loved harping on about how the computer vision tools for breast cancer screening didn't work, right? And all of the evidence in the 2010s that suggested it didn't work. And then the technology has improved, right? Mm-hmm. I don't think I was wrong. I think the technology got better. And then we finally did this big RCT in the Nordics, and we demonstrated that not only can we reduce reporting burden by 50%, right? So instead of having 2 people have to read these scans, now you can do it with just 1 and safely, right? And you can diagnose more cancers and more meaningful cancers, because there's a whole bunch of overdiagnosis problems that we worry about. But you can diagnose more meaningful cancers, and you can prevent what's called an interval cancer, which is a cancer occurring in that 3-year interval between when women women might have been screened. So basically all the signals are this stuff actually works. Breast cancer is one of the single largest oncological killers in Sub-Saharan Africa. It is the leading cause of oncological or cancer-related death for women in Sub-Saharan Africa today. And the real tragedy is because most women who present with breast cancer present late, right? So stage 3, stage 4, at which point you need quite radical treatment. The chances of survival are much lower. And that's really what screening is there to prevent, right? The financing challenge has always been that no country in Sub-Saharan Africa has yet figured out how to afford a national screening program like we're privileged to have in the UK and many European countries have. There exists in the US and many places around the world. I'm convinced there is some really interesting work that we could do in breast cancer prediction and breast cancer diagnosis that would have not just a measurable impact on human life, but a measurable impact on a quantity that people would be quite astounded by. You could achieve with an AI tool or two. But as I said earlier, that's probably not the smart bet. The smart bet, if you're looking for the greatest impact, is the really boring building better health data infrastructure.
Well, hopefully there's enough money in AI and enough attention on healthcare that we can get both in the next 5 to 10 years.
Oh my
that
God.
would be the ideal world.
If someone wants to help me revolutionize breast cancer care in Sub-Saharan Africa, look me up.
Okay. Well, yeah, Bilal, that's all we have time for today, but I think that's a great place to stop. I think it's a positive vision for the future. And for anyone also listening, like, if you heard the call, you heard it from Bilal. So look him up. And Bilal, if people want to learn more about your work, reach out for, to join, what you might be working on, where should they go?
If you're looking for an irreverent take on what's going on in the AI world, look me up on LinkedIn. If you want to reach out, my Path email address is the first letter of my first name followed by my last name, so bmateen@path.org. And then on the Path website, we're always sharing what both Path and our partners are doing in the AI space. So that's always a good place to look.
Well, yeah, thank you. You heard it. That's Bilal Mateen, Chief AI Officer at Path. DM him if you listen to the episode, if you are interested in this space, or just follow him if you want to learn more about his work. Bilal, thank you so much for coming on the show. It's been a pleasure.
Ben, thank you for having me. It's been a pleasure.